So by now, you should already have reviewed the structure and function of all the different types of vessels: veins, venules, capillaries, arterioles, arteries. Understand their structure and their functionality. In this recording, we're going to focus on the factors that affect blood pressure specifically. So here they are. When we want to manipulate blood pressure, we do that to make sure that blood moves from place to place according to greatest need. And remember that blood moves according to a pressure gradient. So if I want to move blood from place to place, I have to create a pressure gradient for it. So these are some of the ways we create pressure gradients and some of the ways we manipulate that overall total blood pressure. So one of the most important things we can do is increase resistance. We're going to come back to that in a second, but resistance is hindrance to blood flow. In other words, if there's one person sitting in our lecture hall and they need to walk out of the room, they're going to be able to walk easily because there's nothing in their way. That would be low resistance. But let's say we put 500 people in our lecture classroom, so it's way over capacity. We open one door and we tell everyone to get out as fast as they can. It's going to be hard for people to get out of that room because their ability to exit the door is hindered, right? There's too many people trying to go through the same space. So that would be an instance of high resistance. So our ability to regulate resistance to blood flow is going to be one of the biggest ways we manipulate pressure. The other way we can manipulate pressure is by heart rate. The more the heart beats in a given period of time, the more blood there is moving through the system in that period of time. And as more blood moves through the system in that period of time, that means there's greater volume, which increases pressure. So increasing heart rate will result in increasing blood pressure. We can also manipulate that amount of blood, the volume of blood, by manipulating stroke volume. Not only can the heart beat faster to increase stroke volume, it can also beat with greater contractility. It can beat harder, which also increases stroke volume. And either way, if you increase stroke volume or heart rate, you will increase cardiac output. So more blood in the vessels at a period of time, and that's going to increase pressure. So let's go back to that concept of resistance. There's three major ways resistance is affected. On a moment-to-moment basis, we can use this: vasoconstriction. Remember, vasoconstriction means to take a relaxed blood vessel, increase the contractility of the smooth muscle around it so that that same blood vessel's diameter gets smaller. So imagine not squeezing on blood in this case, and then all of a sudden squeezing really hard on the blood after we contract the muscle. Vasoconstricting increases resistance because that's that example of having one person go through a door versus 500 people go through a door. The other way resistance is affected is by blood viscosity. That's one of the reasons why polycythemia is not homeostasis, because too many cells in a vessel makes the blood thick. And then thicker blood doesn't move through the vessel nice and smooth, and that increases resistance as well. The third way resistance is affected is by increasing the length of blood vessels. And I said in lecture, this is one of the reasons why obesity is related to hypertension. Because as someone gains weight, they're adding adipose tissue onto their body, which means they're adding blood vessels onto their body, and those blood vessels are getting longer and longer and longer. And as blood travels through a blood vessel, the longer the blood vessel, the more opportunity there is for the blood to kind of eddy and not flow properly and kind of experience sort of friction against the blood in the vessel walls. So the longer the vessel, the higher the resistance. Now normally, on a case-to-case, moment-to-moment basis, it's really vasoconstriction that we're going to use to manipulate resistance. And remember, if I manipulate resistance, I manipulate pressure. So as a quick review, you should be able to answer these questions on your own by this point. Sympathetic stimuli does what to arterioles? And if you increase sympathetic stimulation and you get this effect, how does that change pressure? Also, you should be able to answer this question: what happens to pressure if too many red blood cells are made, and why? And I just gave you the answer to this one as well. Obesity is a factor causing hypertension. So why is that? So here we go again. This concept of changing pressure. We can use stroke volume, we can use heart rate, we can vasoconstrict. We can also manipulate blood volume, the actual amount of blood that's in any given vessel and running through our system. The lower the blood volume, the less resistance, and so blood pressure would drop. The higher the blood volume, the greater the resistance, and so blood pressure rises. And remember, just kind of think about what blood pressure is. Blood pressure is the force of blood pushing against the walls of a vessel. If there's not a lot of blood in the vessel, then it can't push with much force. So pressure's low. If you add more blood to that vessel, it pushes harder against the walls, and that means pressure's high. So again, not only can we manipulate pressure by constricting or dilating blood vessels, we also could manipulate pressure by affecting the amount of blood in there. And so let's think about what blood is. Remember, it's a connective tissue. It's formed elements in plasma, and plasma is mostly water. So can you think of an instance that something you could do that would allow you to lower blood volume? Try to think that through. I also want you to think of an instance where you would increase blood volume. So here's the deal. If I want to manipulate blood volume, I could drink water. Also, if I want to manipulate blood volume, I can control urine output. If I'm urinating frequently, I'm losing water. If I don't urinate, I'm going to keep water. So again, just conceptually think about lowering blood volume through urination and increasing blood volume through urination. The other thing I want you to think about is other ways that blood volume is affected. So in class, we talked about hemorrhage. If you're bleeding, or your patient is bleeding, and your blood is going onto the pavement, your blood volume drops, obviously, because you're losing blood from the body. And in lecture, we talked about the effects of that. As blood volume drops, your body's going to attempt to make up the difference. So one of the things that happens when our blood volume drops, as in the case of hemorrhage, our heart rate goes up. Unfortunately, that causes us to bleed out a little bit faster. So if you're losing blood volume in large amounts in a short period of time, such as hemorrhage, the body tries to make up the difference by raising heart rate. But if your blood volume is low for slower periods of time and really due to, say, you just didn't drink enough water today, then it's not so much about heart rate, it's about manipulating the volume again. Things that would cause high blood volume are hypertension. Okay, hypertension is high blood pressure, and one of the ways that is associated with volume is when someone is sodium sensitive. if you're sodium sensitive, if you eat sodium, where sodium goes, water follows. So as sodium goes into your bloodstream, it's going to carry water with it into the bloodstream. That would increase your blood volume and therefore increase pressure. We, a few moments ago, talked about polycythemia, the fact that that makes blood thick and viscous, which increases resistance. So I'm not going to go through it, but you should be able to sit with a slide, just pause the integrity in a moment, and work your way from here. My pointer's not working. Start at blood hemorrhage, and the fact that if you're hemorrhaging, it's a drop in blood volume, and that drop in blood volume is going to result in these two things. So you should be able to reason out how hemorrhaging is associated with a drop in blood pressure. You should also be able to pause and sit with this mini little case study. If Mrs. Smith is sodium sensitive, when she ate a lot of steamed crab drenched in Old Bay, she ate a lot of sodium. The next day she retained so much water she had to take a prescribed diuretic. So you should understand the effect that salt had on her blood volume, how this affected her blood pressure, and why the diuretic would help. If you're curious or you don't know, a diuretic increases urine output. Alright, so in lecture we said obviously blood pressure is important because blood pressure allows us to ensure blood flow to the tissue that needs it most. Remember, we're going to create a blood pressure gradient to move blood through the body. So we want to manipulate blood pressure, and we want to keep it at a homeostatic level. If blood pressure is too low, we're not going to be able to get blood to move from place to place. We're not going to have that gradient. But when blood pressure is too high, damage actually occurs. You can damage tissue and slow down tissue repair. You can damage the ends of neurons by constant high pressure. So we don't want it too low, but we also don't want it too high. So that means we have to regulate volume and pressure very, very closely on moment-to-moment basis. And one of the themes I've had in lecture is about redundancy. Realize that when something's really important to the human body, the body becomes redundant, meaning it's going to have 2 or 3 or 4 different ways to accomplish the same exact task. And that's what you're about to see. The body's going to have several different ways to manipulate volume and pressure because it's so important. So here's just a few ways. We're going to look at short-term nervous control. Then we're going to look at short-term control using chemical indicators. And then we're going to look what happens in the longer term and how we're going to involve the kidney. So let's look first at that nervous system short-term control. We've got a few things going on here. And remember, it's all about redundancy. One of the things to bear in mind and remember is vasoconstriction. When you stimulate sympathetic neurons, you vasoconstrict blood vessels. That's pretty systemic, except in skeletal muscles. We're going to have the opposite effect in skeletal muscles. So if in the rest of the body I'm vasoconstricting, does that mean in the rest of the body the pressure is high? Yes, it does. So if I vasoconstrict, say, smooth muscle, that means that all those blood vessels deep inside my body and all my organs are under higher pressure. But at the same time, in a time of stress, I'm going to vasodilate my skeletal muscles. So in times of stress, you vasoconstrict vessels and organs, creating high pressure in your organs. You vasodilate in your skeletal muscles, creating low pressure. So if I have high pressure in my organs and low pressure in my muscles, where is blood going to go? You should be able to figure out that blood's going to go to the muscles where the pressure's lower. That's what's going to give my muscles the energy and the ability to run away or fight back. So that's how that's going to work, that vasoconstriction concept. But we don't necessarily have to be under extreme stress to accomplish that. We can use sympathetic nervous system on a moment-to-moment basis to constrict vessels and help me move blood from place to place. We also have this concept of vasomotor tone that's tied to that. Blood vessels are default dilated. So all I have to do is increase that sympathetic nervous system to constrict them. So the tone has to deal with the fact that they're default dilated, and that's in your medulla oblongata. And so that means the medulla can help control constriction. The other way we can manipulate things using our nervous system in the short term is heart rate, right? So not only can I vasoconstrict, which increases resistance and increases pressure. When we first started, we looked at the fact that increasing heart rate will also affect pressure. So I can stimulate my cardioinhibitory center to slow the heart rate down if I need to. That would drop pressure. Or I could stimulate my cardioacceleratory center if I need to. That would raise my heart rate to increase pressure. So the moral of the story here is we manipulate pressure with our nervous system by manipulating heart rate, as is the case in this bottom right corner here, if my pointer would just stay working. So that's manipulating heart rate. We can also use our nervous system in the short term to manipulate diameter of blood vessels. So both of these things are nervous system control, short term, moment to moment, and minute to minute, and they enable me to create those valuable pressure gradients. So that means that I have to have some method of monitoring these pressure gradients and monitoring the environment. And I monitor this environment with baroreceptors and chemoreceptors. Baroreceptors detect pressure. Chemoreceptors detect chemicals or amounts of molecules in the environment. So again, from the top, I can in the short term use my nervous system to control vasoconstriction, sympathetic nervous system neurons. I can also use my nervous system in the short term to control heart rate, with the cardioinhibitory or cardioacceleratory centers. And the reason my nervous system knows if I need to increase or decrease something is because it's receiving receptor input by pressure receptors and chemical receptors. So here's just an example of where some of these are. In the crazy thing. In the aorta here, we have some pressure receptors, and we have some in the carotids as well. That makes sense. We're monitoring the pressure of blood right out of that left ventricle, and we're monitoring the pressure of blood as it heads up toward our brain. So let's go over this again with a couple of examples. If I need to lower blood pressure, let's say right now my blood pressure is too high and I need to get it down. The way we would accomplish lowering blood pressure is by using our vasomotor center to stop action potentials on sympathetic neurons. I'm going to slow down and decrease the number of action potentials I send to blood vessels. That results in the blood vessels relaxing, which dilates them. And if I vasodilate, if my blood vessel gets larger in diameter, that means that the blood inside of it has less resistance, and that would lower pressure. At the same time, I'm going to manipulate heart rate. So if my blood pressure were already too high and I need to lower it, not only will I affect resistance on the blood vessels by dilating them, I'm also going to slow my heart rate by activating my cardioinhibitory center. So I'm going to now fire action potentials on my parasympathetic neurons to my heart. They will kind of override that SA node, and they'll slow down the number of contractions in a minute. So I vasodilated and I slowed my heart rate. That's going to decrease resistance and decrease cardiac output, which will end up lowering my blood pressure. And then once you master that, you just flip it around. So if for whatever reason I forgot to drink water today and my volume and my pressure are too low, then I pretty much am going to do the opposite. I'm going to increase heart rate with my cardioacceleratory center on sympathetic neurons. So I'm going to increase heart rate. That means I'll increase cardiac output. I'm also, it's not typed in here because we talked about it already, but realize I'll also increase action potentials on those sympathetic neurons and vasoconstrict. So we affect blood pressure again with resistance in the vessel and heart rate. And it's the cerebral cortex and your hypothalamus that are paying attention as to whether they need to speed things up or slow things down. So, we can affect the similar concept depending on chemical environments. A drop in blood pressure is usually also associated with a change in the chemistry. If I drop blood pressure, blood's not going to move through that tissue as quickly. And so my oxygen levels are going to drop, but my carbon dioxide levels will rise. And if my carbon dioxide levels rise, then the tissue becomes acidic. This chemistry change would stimulate chemoreceptors. I'd activate that vasomotor center. I'd increase sympathetic nervous system output, which should cause vasoconstriction. That increases resistance and will raise pressure in vessels, which increases blood pressure. So we did the same exact thing, but instead of pressure being the stimulation, a changing chemical environment was the stimulation. And we were able to accomplish either of them with receptor input. So I'm not going to go through these, but I want you to hit pause in a second. Start with hemorrhaging and how that drops blood volume and blood pressure. That a drop in blood volume and blood pressure would be detected by baroreceptors. And how a drop in blood volume and blood pressure changes chemical environments, which would be picked up by chemoreceptors. So we're going to do both because remember, this is important and we need to be redundant. And then work your way through the example on how that change is going to affect cardioacceleratory or vasomotor centers and vessel diameter and ultimately blood pressure. I want you to do the same thing for exercise. Even though we're exercising and it's a wonderful, wonderful thing, that's also going to alter blood chemistry. So I want you to work your way through this flowchart to see how exercise is going to increase blood pressure. So by now, with all that practice, you should be an expert on nervous system short-term control. We're going to talk a little bit about short-term control using chemistry as well. And this, I don't mean amounts of CO2, I mean more like hormones. And when blood pressure drops, or in times of stress, our adrenal medulla, which is a gland sitting on top of the kidney, can secrete epinephrine and norepinephrine. Epinephrine specifically vasoconstricts blood vessels and increases heart rate. Norepinephrine has different effects. The exception to epinephrine's effects is in the skeletal muscle, where I want the opposite. The end result of epinephrine is the same as the sympathetic nervous system. In fact, it's part of the sympathetic nervous system. We're going to vasoconstrict to raise pressure, and we're going to increase heart rate to help us raise pressure. The difference here is I'm doing it by using a hormone on its target instead of just neurons on its target. You do both under times of stress. That's why when something scary happens, your heart rate goes up immediately. That was the nervous system. But it stays elevated for 15 or 20 minutes after the event. That's epinephrine and hormones. The other hormone we can rely on is for same concept but under different circumstances. So this one, for example, would be released at night when you're sleeping. Antidiuretic hormones released from the hypothalamus. It stimulates water reabsorption in the kidney and vasoconstriction. So ADH is the reason why you wake up in the morning and hopefully you haven't peed all night long. And the urine in the morning is very, very concentrated because you've been reabsorbing water out of that filtrate and keeping it all night long, returning it to the blood. So we would do it at night. We would also do it over the course of hours to days, a few days, if we were dehydrated. We're going to use the same mechanism to conserve water. So this, again, is going to affect pressure by affecting the amount of blood in those tubes. And it's manipulating urine output to affect the amount of blood in the tubes. Then for fun, I tossed in alcohol, ethanol, booze. Alcohol inhibits ADH. It also acts on vasomotor centers. It causes vasodilation, and that's an ultimate drop in blood pressure. So I threw alcohol in as, not that your body's producing it and using it as a hormone, but so that you could see how chemicals from the outside environment affect the human body. All right, so let's say we still haven't solved the problem. Let's say we used short-term nervous system controls and we couldn't get pressure gradients to be what we need. And we used short-term chemical controls, we still couldn't get pressure gradients to be what they need. So now we're going to resort to using the kidney. One of the things the kidney does is because the kidney filters your blood and creates a filtrate that it excretes, that's urine, we can use the kidney to manipulate urine output immediately. So we're going to come back to the direct method eventually when we get to the urinary system, because it involves discussing functional unit structure of the kidney, and we don't want to get into that right now. So as far as the direct method is concerned, just understand for now that the kidney filters blood and excretes urine. So a lot of blood is going into the kidney. So the kidney can directly affect blood pressure. What I want you to focus on right now is the indirect method. So the kidney is going to directly affect blood pressure by locally manipulating urine output. If your blood pressure was low for a period of time, in addition to ADH and in addition to everything else, your kidney on its own would decrease urine output to save water and to try and save your blood pressure. Your kidney's also going to react using the indirect method. So what happens here is our kidneys secrete a molecule called renin. You could say renin, I don't care. When renin is released from the kidneys, it stimulates production of a molecule called angiotensin II. So you see it here. Okay, so if your blood pressure is low for a period of time, your kidneys secrete renin. Renin acts on something called angiotensinogen and converts that to angiotensin II. Angiotensin II does two things. One of the things it does is angiotensin II is a potent vasoconstrictor. So if blood pressure is low for a period of time, kidney secretes renin, we end up getting an increase in angiotensin II. Angiotensin II vasoconstricts blood vessels. So if we vasoconstrict all these blood vessels, we increase resistance and start to increase pressure. The second thing angiotensin II does is it stimulates production of aldosterone. Aldosterone, in turn, tells structures in the kidney to reabsorb sodium from the filtrate. So instead of having sodium come out in the urine, you're now keeping it and returning it to the blood supply. Do you remember what I said with Mrs. Smith? Where sodium goes, water follows. So by having aldosterone stimulate sodium reabsorption in the kidney, we make sure that we increase blood volume. All right, nothing like your phone ringing in the middle. So again, if blood pressure was low for a period of time, kidney would secrete renin. Renin causes conversion of a precursor molecule to angiotensin II. Angiotensin II does two things. It stimulates vasoconstriction, which increases resistance to increased pressure. It also causes production of aldosterone, which acts in the kidney to increase sodium reabsorption. So if you take sodium out of the filtrate and you put it back into your blood, that means you're also putting water back into your blood. You will increase blood volume, which will also increase pressure. So I'm not going to go through this, but again, I want you to pause the recording, and I want you to work your way through this flow chart. I want you to start way up here on the upper left where I'm circling, where if arterial pressure is low, what's going to happen? And to start you out, when there's a drop in arterial pressure, you're going to detect that with baroreceptors, which are going to affect sympathetic nervous system. And you can see here, sympathetic is tied to the kidney. And you're also going to directly affect the kidney in a couple of different ways. So I want you to be able to understand the renin angiotensin II pathway and the effects of ADH. So that was indeed all extrinsic. That was all outside the organ system. So now let's look inside the organ system. And remember the phenomenon that's going to move blood through the body. Blood flows according to a pressure gradient, and it'll move wherever one vessel has a larger diameter or less resistance. So it's going to flow from high pressure or high resistance to low pressure or low resistance. Understand why capillaries, the flow through capillaries is the slowest, and it is related to cross-section area. If we actually just look at area, you have the largest number in capillaries compared to everybody else. All right, so changing diameter of a blood vessel. We're mostly going to be dealing with arterioles here, and arterioles have the ability to do something called autoregulation. It's short and long-term control, but they have the ability to self-regulate their diameter. So in addition to all that other stuff, the sympathetic nervous system, blood vessels can do it themselves as well. And if it gets confusing, remember the body's redundant because this is important. All right, so autoregulation is an automatic adjustment of blood flow to each tissue in proportion to its requirements at any point in time. So it's the ability of an arteriole moving through a tissue and organ to self-constrict or self-dilate in response to local chemical conditions. And this is happening outside of that whole sympathetic nervous system. It's a blood vessel understanding the environment it's running through and changing itself because of that environment. So there's a few metabolic controls that help us do this. One of the stimulation is a drop in oxygen. When oxygen levels in a tissue drop, that's detected just locally in the arteriole, and it automatically stimulates vasodilation. That makes sense because if oxygen levels drop, that means this tissue is metabolically active. We want more blood to come to this tissue, so we're going to dilate blood vessels to decrease resistance, which drops the pressure, and blood is going to follow. The exception to this rule is in the brain, where the stimulus is rising carbon dioxide levels. But rising CO2 is also an indicator of metabolic activity. The other indicators, because again, redundant, because it's important, are rises in these things. Potassium ions, hydrogen ions, lactic acid, histamine. These are all indications of metabolic activity or inflammation. And that's going to also vasodilate. We also have myogenic control, which is moment to moment as well. Within a given arteriole, if the pressure rises in it, the blood vessel stretches. When pressure drops, the blood vessel has less stretch. So even just stretching a blood vessel causes them to respond because they're made of smooth muscle, and smooth muscle has a stretch relaxation response. So if you stretch, it responds by vasoconstricting, in this case, to decrease flow. And if there's less stretch, they'll actually begin to dilate to increase flow. So again, it's smooth muscle, which behaves differently from all the other muscle tissue types. And it has its own little reflex response. And that's what you're seeing here with myogenic control. So the thing to understand, that myogenic control is moment to moment. It's stretch or less stretch stimulating a response because this is smooth muscle. In the long term, if it's still not enough, we're going to have to resort to things that are drastic. So this is like days to weeks. So over days to weeks, if we cannot manipulate pressure in order to meet our needs, one of the things we can do is increase the number of blood vessels. Remember, the number of blood vessels, and the longer the blood vessels, the more resistance, which means we'll rise pressure. But unfortunately, that's also going to happen if we get fat. We can also take some existing blood vessels and enlarge them, make them bigger. And we especially do this in the heart and in the coronary vessels if they become occluded with plaques, or we're at high altitudes and the heart just can't get enough oxygen because there's not enough oxygen in the air. So even if none of all that stuff that came before this works, we have a few other options by just manipulating the anatomy itself. So the next thing we switched to and focused on was capillary dynamics, movement of fluid in and out of capillaries. You should stop and review these terms. Remember, we're dealing with the same fluid, but depending on where the fluid is, we call it something different. Here we are. Up here on the top, I have a blood vessel. That fluid in there would be plasma. When the fluid leaves a blood vessel and it's between cells, we call it interstitial fluid. Some of that fluid can go back into the capillary. Some of it can be picked up and gathered up in a lymphatic capillary. To summarize the concepts first, when we do exchange at a capillary, exchange is driven by gradients and most of the time just diffusion or osmosis. So that means in order for us to get things back and forth across a capillary, we have to have gradients. And here's how we're going to do that. As blood comes into a capillary, because of the proteins in the stuff and the pressure of the blood itself, there's a force, a pressure, pushing out of a capillary. That pressure pushing out is the hydrostatic pressure. And it's due to the plasma proteins and the pressure of the blood in that vessel. On the outside here in the interstitial fluid, also due to proteins and stuff dissolved into this interstitial space, there's a pressure pushing back inside the capillary. That's called osmotic pressure. The tissue osmotic pressure is constant all the way across. It doesn't change at all. But hydrostatic pressure does. So at the arterial end, hydrostatic pressure, the pressure of that blood coming in, is greater than osmotic. That means the pressure pushing out is bigger than the pressure pushing back in, so fluid leaves the capillary. At the venous end, the story changes. There's a dramatic drop by the time you reach the venous end. We're pretty much at zero pressure here. So at the venous end, hydrostatic pressure is lower than osmotic, which now means that the pressure pushing out is less than the pressure pushing back in, and this drives fluid in to the capillary. So we go through great effort to try and maintain the balance between these pressures to ensure fluid out at the arterial end, but fluid in at the venous end. Anything left over gets picked up by the lymph. So again, capillary hydrostatic pressure is the fluid pushing against the walls of that arterial end of the capillary. It is a force pushing out. It's higher at the arterial end, but it's next to zero at the venous end. Osmotic pressure is osmosis. That's the force of fluid pushing back into the capillary. It stays constant throughout because it's the force associated with the osmolarity of the interstitial space. I'm not going to go through it, but obviously this is the same concept in a different representation. At the arterial end, we favor filtration because the capillary hydrostatic pressure is high and fluid leaves. At the venous end, we favor reabsorption because capillary osmotic pressure happens to be greater than hydrostatic. The hydrostatic drops, and so reabsorption gets favored. If we don't balance that, we get edema. So edema happens when you have either just too much filtration or not enough return. In lecture, we talked about edema. It really is the failure to return excess interstitial fluid, and it begins to collect. Here's a few things that could cause too much filtration. People who have hypertension tend to get edema because their pressure is already high. So that means their capillary hydrostatic pressure at their arterial end is way too high, so you get tons of filtration. Sodium retention in people sensitive to it will also cause edema because where sodium goes, water follows. So if there's too much sodium in the blood, there's too much water in the blood, and the capillary hydrostatic pressure is too high, so we get too much filtration. When someone has congestive heart failure, that means the ventricles aren't contracting as well as they should. And so you're getting decreased venous return, and blood starts to pool in areas. And when blood pools because it can't move properly through the system, that affects capillary hydrostatic pressure, and you get too much filtration. And another example is incompetent venous valves, such as the case with varicose veins. Same concept. Blood begins to pool, which affects hydrostatic pressure. The other way you can get too much filtration is by affecting permeability. You make the capillary itself too permeable. So allergic reactions do that because that's inflammation. That's the goal of an allergic response, is to increase permeability. But if you burn or crush the capillary bed, you would also get edema because physically you've destroyed the structures. In class, I had you go back to Miss Smith and talk about what really happened now, put it all together, and why she swelled up like a balloon. And then I also talked about a gentleman I once knew, a very, very sweet man, who we always thought was just a big guy, just kind of a heavy, obese guy. And then he went into the hospital one weekend, and he was hospitalized for congestive heart failure. During his treatment, he was put on diuretics, and he lost 60 pounds of just water. The fluid had collected in him because his heart couldn't move blood correctly. So his hydrostatic pressure systemically was just way too high, and he had too much filtration. And this is what happens with congestive heart failure. Some of the common symptoms: you get coughing because fluid collects in the lungs, and the lungs are trying to expel it. That's pulmonary edema. Congestive heart failure is when the heart just starts beating weaker and weaker. Because you're not moving blood through the body, people tend to get very tired and be very, very short of breath. They can also get edema in the abdomen, so they get swollen bellies, and also very typically swollen ankles and legs. And the gentleman we knew very much looked like that. Interestingly, if the right side of the heart fails, blood does back up, but blood backs up in such a way that it's, your right ventricle's failing, so blood's backing up past right atrium, blood backs up into the inferior vena cava first because of gravity, and then, what vessels are really close to that? The vessels close to that are the jugular veins. So you can see distended, swollen jugular veins here That's an indication of right side failure. Left side failure, blood's backing up, but blood backs up into the pulmonary system, and so you get pulmonary edema or rales forming. And you're seeing this cloudiness here shouldn't be here. This cloudiness is an effect of pulmonary edema. So edema can also be caused by too much filtration. It could also be caused by too little return. We see that in the case of starvation. I mentioned in lecture that's why starving children will have those big bellies. That's not fat, that's edema. And the reason is because the colloid osmotic pressure is way too low. So the force pushing back into the capillary at the venous end is too low. So you don't get enough fluid returning. The reason is they can't maintain osmotic pressure because there's not enough plasma protein, because there's not enough protein in the diet. Individuals with kidney disease will also get a similar kind of edema. And even though they might have protein in the diet, the problem with kidney disease is they lose proteins in the urine. They don't have the ability to keep proteins in the blood. So the proteins leave the blood and they come out in the pee. So that means you're losing proteins. You cannot maintain osmotic pressure, so you get less return. Right, so that's the end, and hopefully that helps.